India could do this for the world. Now, we should reclaim all the glory and the credit back. Often you only see European names and American names. These are those names. Billroth Cocker. All of us know Theodore Cocker. Billroth was the first one who did a total laryngectomy, gastrectomy, apart from many other procedures. Cocker, the transverse skin crease incision we give in the neck to do a thyroid or any neck dissections, is called Cocker's transverse skin crease incision. Few other names that are never heard often are the Henry Butlin, Hayes Martin. I think some of us would have heard of Hayes Martin, the tying of facial artery below the mandible to avoid injury to the marginal mandibular nerve. George Cryle is the famous name, and Manuel Garcia, the mirror that we are all using to visualize intraoral or to be specific, the indirect laryngoscope. He didn't invent that, but then he used that. It's the application of mind. He used that mirror to visualize, using the sunlight to visualize the larynx. So imagine, this was before mobile phone, before YouTube, before Google. There was no electricity, and they could invent so much. If they could invent so much, what are we capable of today? So head and neck oncology is actually a relatively young field. The reason is, before 16th century, there were not many oral cancers. The reason is that, the reason is that there was no tobacco. There was no tobacco in the form of an industry. Now, before 18th century or 17th century, it was often attributed to syphilis or some infection that is causing all these malignancies in the oral cavity. But then, as the industrial revolution happened and as colonization happened, Europeans are everywhere. They are in Pondicherry, they are in Tarangambadi, they are everywhere. Be it French, be it Dutch, Europeans colonized the world and did enough to the world. And the gift that they gave us is tobacco. So, before 16th century, the prevalence or incidence of oral cancers were far and few. And they attributed it to infections like syphilis or sexually transmitted diseases. But with the advent of industrial revolution and tobacco becoming an industry, and see, you can get a cigarette now. I'll share you that statement. So in 1800, so what I meant was that the head and neck oncology as such is not more than 150-year-old specialty, right? So late 1800s, that is almost 1868 to 1880, Dr. Henry Butlin first proposed an idea of removing electively lymph nodes to cure any subclinical disease that, if at all, present. See, this was again the era where anesthesia was not there, antibiotics were not there, that surgical prophylaxis or blood transfusion was not there. Yet at that time they proposed this idea that removing lymph nodes electively, even if they are not involved, may cure any subclinical disease if at all present. Now, this was the statement from Disease of Tongue, the book written by Henry Butlin. When the primary disease is limited to one half of the tongue and can be removed with sufficient area of healthy tissue around it to practically ensure the patient against recurrence, the anterior triangle should also be cleared out. See, in 1800 or late 1800, somebody told you that you have to give margins for your tongue disease, and somebody told you to do elective neck dissection. We took 200 years to prove it and then follow it as a norm. So this is what I meant when we said all of us have to be way ahead of our time and open our perspectives. So at a time, again I keep repeating this words, at a time, because it surprises me. At the time when antibiotics are not there, anesthesia was not there, the procedure must have been cruel and painful, they could give 30% cure rate. So after Dr. Henry Butlin proposed this idea of electively addressing lymph nodes, have commando procedure as the name. May I know why it has come? So interesting thing is that, so now we have come, the prehistoric era is over, we are now relatively in the modern era, and again what Europe and the West gave to us is war. During this World War era, enemies were attacked from both the sides to encircle or target the enemy and win the war. So in the same way, and this was called commando operation or commando operation in military. Now oral cancer now is being seen as enemy. It is being approached intraorally as well as from outside, removing the tumor and all the intervening tissues, including the mandible and the lymph nodes, in an en bloc fashion, and thus give survival advantage as well as clearance with respect to oncological outcomes. So this so-called commando approach led to the induction of this term commando operation for advanced oral cancers. And A. Martin, Grant Ward, Hendrick, and all these other European surgeons have contributed to the advancing the modern head and neck cancers. So moving ahead, the next topic on tobacco, I'm not going to talk that all of us know tobacco causes cancer and there is no conflict in it. But will you believe the time or the era when tobacco was not even considered as a causal factor for any cancer? And it was not in 18th century, mind you. Until 1940s, tobacco industry was so strong that they could propagate their idea that tobacco is not the cause of cancer or any other diseases that it is now attributed to. So this is called denialist propaganda. What they would, sir, Raghu sir, you were saying we are going to have a talk on branding, positioning, marketing in our forums now. Back then in 19th century, tobacco industry was so good that they could position themselves as a refreshment or lifestyle company. They were providing refreshment apparently to the smokers and not giving cancer. So that was their propaganda, and they were successful for over 150 years. Until in 1940s and 50s, when the epidemiologic studies, the animal studies and the lab studies proved definitive carcinogens in it, they didn't take back their statement. So during that era, in somewhere between 1920 to 1950, the scholarly knowledge of the understanding of carcinogenicity of tobacco, they could gain it. The scientists could gain it. But then the non-scholars or the corporates or the ones who drive the propaganda, they couldn't think what they were thinking. So the rise of scholarly knowledge of cigarette carcinogenicity was there, but then scholars didn't pay enough attention to what non-scholars have thought about the world, and this is called agnotology. And now there have been tremendous efforts to generate this ignorance among the people, and they had the audacity, the industry had the audacity to issue a statement called a frank statement to cigarette smokers. And in fact, if you see here, it has written, for more than 300 years, this is an official statement, and this is coming from the tobacco industry, and we have all approved it. So for more than 300 years, tobacco has given solace, that is comfort, relaxation and enjoyment to mankind. While the scientists that have come now are proposing that it is causing cancer, A, B, C, D, coronary artery diseases, stroke, all these things. So today it seems difficult to imagine a time like that when tobacco and cancer were not causally linked. So all of us are Arul sir was telling ethical practice. Now what do we call this? So industry is somewhere beyond our understanding. And when we talk about I think enough of history. When we talk about tobacco, all of us should know, anybody who is practicing head and neck oncology should know Slaughter's processes. Slaughter's hypothesis is that oral epithelium is preconditioned by, even at that point tobacco was not recognized as carcinogen. So oral epithelium is preconditioned by an unknown carcinogenic agent. This is called field cancerization. The implication is, it means that somebody consumes tobacco, wherever it has gone, that entire field may have premalignant changes. That is all it implies. So somebody consumes tobacco and has developed a gingiva buccal sulcus lesion. It doesn't mean that he is not Now, I think a lot of time taken on history and tobacco. Going to the serious part of this topic, is technology bad? All the gadgetry, do you all think that too many gadgetry inside the operation theatre, is it bad? According to me, a right tool in a right hand at a right cost will only help the patient as well as the treating team. So, in the diagnosis, I am not like I said, I am not going to bore you with all the routine. All of us know that we do biopsy to do diagnosis, we do CT scan, we do MRI, blah blah blah, all that, but nothing. So what are we doing differently, and why are we here? So that is only to showcase the newer things that we are doing, and probably we want to showcase that it doesn't come with a price. This is not new anymore. We are already outdated is what we wanted to showcase here. So all of us know PET-CT is used for staging of the disease. Now the routine PET-CT that is available across is FDG PET-CT. That is based on glucose transporter. So wherever glucose transporter is there in the cell, this radio tracer will attach or bind to that glucose transporter glut and then go into the cell. So all cancer cells are supposed to be hungry and craving more energy and more glucose, and thus malignant cells wherever they are will take this radio tracer and show activity which lights up on the PET-CT. This is the routine, this is the normal FDG PET-CT. Now the drawbacks in FDG PET-CT are that infection also will be hungry and craving for more glucose, and inflammation trauma will also be hungry and will be craving for more glucose, and henceforth lights up on this. So tumor, infection, inflammation, everything will light up on FDG PET-CT. And particularly in India, when tuberculosis and upper respiratory tract infections are more prevalent, most of us, if we do a PET-CT, also will have mediastinal lymph nodes with some minimal SUV, minimal activity of FDG. So this confuses the picture, particularly when there is an oral malignancy, for example, and then mediastinal nodes will light up on FDG. It confuses the picture. Whether are we dealing with metastatic disease or not? So to avoid all this, and also to get a better resolution of the primary, so this has come up. What is FAPI? So any cancer and the stroma around the cancer will have cancer associated fibroblasts. These fibroblasts secreting, these fibroblasts help in the tumor growth, migration, metastasis progression locally as well as elsewhere. So what happens is they express fibroblast activation protein. So FAP is fibroblast activation protein inhibitor. Now what we are using is, we have put a radio tracer called gallium to this, attached to the FAP, and then same procedure like FDG PET-CT, we are doing it at the same cost. Now the advantage is that its uptake is exclusively in this fibroblastic activating protein, which is only present in cancer cells and not in infection and inflammation. Henceforth the resolution is better, we can demarcate the disease better, and if at all something is missed or overdiagnosed in FDG PET-CT, it could be corrected with FAPI PET-CT. The low background noise is also there, and henceforth the primary tumors are better delineated. I'll show you the pictures to make you better understand. So this is some soft palate malignancy. There is a malignancy between soft palate hard palate junction. Now this is FDG PET-CT. There is diffuse activity. We don't know where the tumor is, and even in axial sagittal section. In axial sections, we don't know there is some diffuse activity. Corresponding CT image does not show any lesion here. Corresponding CT image does not show any lesion here. Lot of activity in the brain which is normal. Now, if you compare it with the FAPI PET-CT, exclusively the tumor is highlighted. There is no background noise like this. There is no background noise like this. The tumor is well lit on the corresponding CT as well. And even on the sagittal sections, you compare this with this. This is the same patient. Now, there is no noise. There is no noise of the uvula. There is no noise of the normal tissues in the palate. The tumor alone is well demarcated and picked. What was missed on PET-CT, that is FDG PET-CT, was picked up by the FAPI PET-CT with clear demarcation, no background noise, and no confusion. And surprisingly, this lesion was even missed on MRI. In all the sequences of MRI, you just see some activity in the contrast, that's all. But the lesion is not well demarcated. While in PET-CT, there is a clear, FAPI PET-CT, there is a clear-cut lesion. So, the second image, this is the FDG MRI is confusing. There is something beyond here. Now, if you see the FDG PET CT, FAPI PET CT, it has clearly demarcated the lesion and told us that it doesn't have any intracranial extension, and there is some sphenoid erosion here, but then that can be taken care of. So, FAPI PET CT is the new kid here. It's not new technically speaking. It's almost 5 to 10 years. It has been in the practice. We do FAPI PET CT here at Mayon. The advantages are that, to summarize on FAPI PET CT, it identifies disease that is missed on FDG PET CT. If at all, if the disease is identified in both the scans, but the advantage with FAPI is that it clearly demarcates the primary as well, and then there is no background noise or activity that confuses in the management. So that's the new kid about FAPI PET CT. According to me, the best advantage of FAPI PET CT is not just this. Now, in FDG PET CT, it can only be used for diagnostics. But FAPI PET CT, you add lutetium to it. It is another radiotracer molecule. It will go and give treatment also to those subsites. I'll give you a case scenario. For example, a patient, oral cavity, operated, all well, 5 years. 6th year, developed some metastasis. You remove that as well, or you give chemotherapy radiation, that has also been cured. 8th year, he developed multiple metastases everywhere. If there is a FAPI PET CT at that point, and if FAPI activity is present in all those metastatic sites, let's say there are 100 sites of metastasis. If FAPI activity is there in that, you tag lutetium to it, give that injection. Wherever this FAPI activity is there, this radiotracer along with the lutetium will go there and will act. It is the targeted therapy. So, with FAPI PET CT, therapeutics is also possible, and this is called theranostics. There is therapeutic potential as well as diagnostic potential, and henceforth FAPI PET CT is it is a very promising tool. So moving ahead, TNM 9th edition has come, probably I think it's been 2 months that 9th edition has been launched. Glad that we could contribute to this as well through UICC and AJCC. From when I was in Adyar Cancer Institute, our team contributed and proposed certain ideas and then glad that we could bring those points in the table that I'm going to show you subsequently. Now, I'm not going to bore you with the entire clean and staging. That is all for, it's a memory. You just have to buy habit. But then the significant changes or the remarkable points that were confusing earlier has now been resolved. Glad that we are. If there is a superficial, the first point, if there is a superficial erosion of the bone, be it on the gingival surface or in the mandible or in the maxilla, and there are no malignant cells seen in it cannot be stage T4A. If there is so to simplify that, there is a large tumor in the gingival sulcus, there is bone erosion on the CT scan. We have staged it clinical T4A. We are not wrong in that. But then the final stage after the surgery, the pathological staging, if there are no malignant cells in that eroded bone, or if the marrow is not involved, you cannot name it T4A. You have to downstage the tumor, which will improve the survival, which will make a lot of change in prognosis as well as treatment. The second point, that is trivial. So this depth of invasion and tumor thickness. So there was a lot of, this concept was there in TNM 8 as well. Now there is a better understanding of depth of invasion, the difference between depth of invasion and tumor thickness. The difference is that, see, this is the mucosa. The blue thing is mucosa. Depth of invasion is that the closest mucosal breach. So that is your first dimension. The second dimension is the farthest it has reached, that is the deepest point of invasion. So from the closest mucosal surface breach to the deepest point of invasion is the depth of invasion. Now, this lesion is within the mucosa, and henceforth the depth of invasion has become is equals to the tumor thickness. So it's a flat tumor. For example, if it is an exophytic tumor, so the tumor has grown beyond the mucosa. Now, depth of invasion, as per the definition, is from the area where there is a mucosal breach to the deepest point is depth of invasion. So this red line is the depth of invasion. While tumor thickness is the entire thickness of the tumor, from whatever you see visibly to the deepest invasion, point of invasion. So should become T2. But then after surgery, if your pathologist gives you T1, don't get offended. So this is what it means. And if it must have been an exophytic tumor that we had over calculated the size. But prognostically, what is important, the carry home point from this slide, the prognostically important point is that depth of invasion is only in the staging. Tumor thickness is not in the staging. Tumor thickness is what we see in clinic. But what pathologically depth of invasion is there, that only is in the staging, and that carries prognostic value and treatment value as well. So in this slide, 2 points: superficial bone erosion without malignant cells on pathology is not T4A. You have to downstage it. Depth of invasion is important. It was already there in AJCC TNM 8th edition. Now there is clarity on in 9th edition about the differences between everything. Now, clinically extranodal extension, if a large 6 cm nodal mass is there from a primary oral cavity malignancy, how do you call it a clinical extranodal extension? Earlier, it was a random weight definition. If it was not mobile, it was big, it was hard. These are all subjective. What is hard to me may be soft to somebody else. What is big can be not so big for somebody else. So, instead of having weight definitions, now we have clarity on it. If there is a presence of skin involvement over the node, if there is an ulceration over the node, even if it is 1 cm, it becomes clinical extranodal extension and it makes it N3B. Now, if it is fixed to the deep structures like underlying muscle or adjacent anatomical structures, that causes clinical signs like, if for example, if there is a nerve compression, marginal mandibular nerve compression and paralysis of the commission, that can also be called as clinical extranodal extension. The idea here is that there is an objective definition now for clinical extranodal extension and there is no vague definition like earlier. And then there was always this confusion. Pathologists call and ask, if they will give a 1A node, they will call and ask, sir, is this left or right? Now, there is nothing like left or right in midline nodes, the last point here. All the midline nodes are considered ipsilateral nodes. Then, so what is a good quality neck dissection? What is a good quality neck dissection? I did, it is good. Somebody else did, is it bad? It's not like that. There is a definition now. Earlier, there was a definition from ASCO, American Society of Clinical Oncology. They said that if you remove at least 14 lymph nodes, if a proper lymph node dissection is done in a high quality center and the yield is 14 lymph nodes, it is considered a good quality neck dissection. Now, there is better. Now, if I do only selective neck dissection, if I am only removing 1A, 1B and 2, I cannot get 15 nodes, 14 nodes. So, it is ridiculous. Now, there is a clarity on this. If a selective neck dissection is done, so this idea has come from the philosophy that less is more. Now, we are done with radical surgeries or radicality or removing more is better and a concept poetry. Now, this selective neck dissection is valid, is adequate oncologically. If you are doing that, if the yield is 6 or more nodes, that is enough. If you are doing a radical or modified radical neck dissection, there must be at least 15 or more nodes. So, less is more. Selective neck dissection is applicable. We have it in TNM now formally. If you are doing selective neck dissection, if it was a properly done job, 6 nodes is adequate to call it a good quality neck